Hello, we're going to take a moment to discuss a tool that's going to be used under the new Patient-Driven Payment Model, or PDPM. So as of October 1st, 2019, we are going to be changing the way we get paid for our Medicare patients. So currently, everything that we look at in regards to when we take patients and what we're going to cover them for, therapy has played a big role in that. We're always looking to see, do they have therapy? Do they have a need for therapy? It's very therapy driven. Come October 1st of 2019, that will no longer be the case. CMS has basically taken a look at how we've been paid over the past several years and made a determination that they want to take the incentive away from providing therapy services only and focus more on the clinical components of what we do for care in the SNF. So currently, you take a lot of ortho patients. Those are the people that get cherry-picked by all of our competitors. And when it comes to October 1st, there's going to be more of an impact and a focus on those clinical train wrecks, for lack of a better word. And CMS was very thoughtful in how they did this, because there are people that currently will stay in a hospital because no one wants to touch them because they are considered to be high-cost patients, and there's no return on investment. No profitability for that. So people that had tube feedings and wounds and certain types of diagnosis were maintained in the hospital for 30, 45, 60 days, awaiting some sort of placement to get some sort of a restorative or rehab intervention, just because facilities were kind of leaving those folks in the hospitals. So CMS is trying to change that whole dynamic. And again, as of October 1st, that will change. And that's why we're changing the way you're looking at folks in the facility, in the hospital, before they come to the facility. The first disclaimer I want to make is that this tool by no means is meant to change your current process for how it is you look for patients, you refer them, you accept and deny. There's no bearing on anything on this tool. The enhancements that we've made to your screening process have no indication about whether or not we should take a patient based on the amount of check marks or the lack of check marks that are placed on this tool. So again, this is not meant to change that process. David would be very stringent to say to you that your two primary, as a clinical evaluator, your two primary focuses are, can we take care of the patient based on clinical capability list for the facility, and do they have a viable payer? Those will still be your two most important questions to ask. And then this is really just meant to jumpstart the documentation that we will need at the facility when the patient comes, to make sure that we're getting paid and reimbursed appropriately for the level of care that we are going to provide for this patient under the new system. So with that being said, this tool has already started to be used in the field by the clinical evaluators. They are going to use it over the next month or so and make different changes to it to come up with a final draft of this tool and how it will be used across national healthcare. So it might be that, we have to take some things off, add some things on there. We're trying to combine any tools that the clinical evaluators are currently using. So you will see that over on the right-hand side here, they've already started to make some changes to the tool as it has been presented earlier in a draft form. But the concept is still the same. So a clinical evaluator is out in the field looking at patients, making referrals, making bed offers, and now they will start to incorporate this tool into that process. It's been said that you really won't put the effort into looking for and putting all of these check marks until you know that the patient is going to come to the facility. Okay, so there may be a lot of people that you're not quite sure, and you've got lots of things, lots of irons in the fire, but until you know that they're coming, then you may not want to invest the time into looking to all of these things. But the tool was meant to be very simplistic, and it would not matter whether a clinical evaluator had any sort of nursing background or clinical background. Anyone would be able to kind of recognize these very layman term type categories. So you can pretty much know if someone's got a skin issue, if they have a respiratory problem, if they have an ongoing infection, if they're exhibiting some behaviors. Diabetes is one that sticks out, that they have nutritional problems, or some of the other diagnoses. So these headers that are in yellow are meant to be very vague and to give you highlights of where it is that you might be focusing your attention when you hear these kind of buzzwords. In addition to the clinical evaluator being able to use this tool, once it gets sent to the facility, it's also used by the MDS coordinator and can be used as a visual prompt for the administrator. And we'll talk a little bit more about that as we progress through this training. So if you were to look at a patient in the hospital and you see that they have 2+ stage 2 pressure ulcers, you would simply just put a check mark there. All right, or maybe they had a stage 4 or an unstageable area. Whatever the situation, you'd simply put a check mark there. By hovering over the yellow part, it tells you what sort of medical records we'd be looking for from the hospital to support that service in the facility. So we'd be looking for TARs, which are your treatment sheets, wound consults, and perhaps infectious disease notes. Somebody has pneumonia, or they're using oxygen, or have nebulizer treatments, or a diagnosis of asthma and COPD. A simple check mark by the clinical evaluator, and for their own review, they can go up again to the respiratory and see that we'd be looking for respiratory consults and notes and MARS. Does the person have an infection or some sort of a fever going on? Do they have HIV? Do they have impaired cognition? And if you say that they do, again, a prompt to tell you that perhaps we could have some psych notes or social service notes from the hospital. What we're trying to do is streamline how many pieces of paper we need to get from the hospital. So sometimes we're getting 500 pages and there's nothing in there. So if we can get it down to 10 or 15 or 20 pages of relevant information, it's going to clean up and make this a very efficient practice. You've already requested the stuff from the hospital. It comes to us by the time the patient's there, along with the referral and their discharge. Everything is all tidy. The MDS coordinator can review the sheet that you've checked off, can look at the medical records that eventually came to us, and be able to say, well, geez, I don't see anything in here about asthma and COPD, but I know that they saw it in the hospital documentation because the evaluator put a check mark here. So that would allow the MDS coordinator to further pursue additional information from the medical record. Now, we are trying to make it so that the MDS coordinators will have access to any hospitals that allow it to the EMR, so that we would be able to go and get the information we know we need, as opposed to relying on others to send us what you think we need. So again, the tool is meant to be something that works not only for clinical evaluators in the hospital setting, but then to transition over into a use into the facility. So when I say that, an MDS coordinator that receives this after all the check marks are in here and the evaluator fills out all of their other things, whatever the final form looks like, now an MDS coordinator, the director of nurses, the administrator can look at these check marks and where they're placed, and they can kind of make a determination not only about what they need to do for the environment to care for this patient when they come, but also where they might fall in a payment category in regard to PDPM. So you will see letters next to some of these services or conditions, and that indicates the level that they would be in a nursing category if it impacts it. So the stage 2 would be a special care low in the nursing component. Asthma, COPD, would not only be an H in the nursing component, but would also get 2 NTA points. The asterisks indicate NTA points. So those are add-ons. People that have something with a letter in parentheses as well as asterisks, that's double. All right, so for a clinical evaluator, again, this is not important to you. You want to make sure that we can care for the patient and we have a primary payer. But once this comes to the MDS coordinators in the facility, this becomes relevant to us in being able to predict where we will have someone fall, what the costs will be associated with caring for this patient, as well as what the expenses will be for caring for this patient. So again, it's a tool that transitions between all the departments and with the patient through their care. So in addition to all of these sorts of things, the administrator could have a copy of this cheat sheet. And when you're in morning report and you're trying to think of, under this new system, trying to get familiar with it and know the buzzwords that might make you have an increase in your payment, you would hear things that are on here. And so all of a sudden somebody now has had weight loss, and it might stimulate an administrator or someone using this tool to say, hey, they didn't have weight loss before, but they have it now. Should we look at doing an intermittent payment assessment, an IPA? Would it change our rate? All of a sudden somebody has a diabetic foot ulcer. hey, that's a new NTA point that we didn't have before. Would it impact us enough that we'd want to do an IPA? So again, as far as a clinical evaluator, this really means little to you, but once the tool comes to us in the facility, it's very useful. From a clinical evaluator standpoint, again, I'm going to stress you're making sure we can take care of the patient, that we have a viable payer, and now you are jump-starting the medical record that will come to us to support the payment that we need to receive to take care of these patients under the new system. There is a spot down here below, so once we've put all of our check marks in and we've requested the information, we can simply say that, yes, we've requested MARS, yes, we've got TARS, yes, we had some consults that we were able to get. We have a discharge summary or we've requested one. So at the time you're doing this, you probably very well don't have a discharge summary. Sometimes that's not done for a day or two, but we should at least request it while the person's there to be sent over. And then in Connecticut, there's something called a W-10. So they may be checking that off. Everyone should get ER notes and an HMP that's from the hospital. So a lot of times someone's in the hospital for 3, 4, 7 days, but we don't send the ER records when we send over the referral. And the ER records hold a wealth of information, especially under this new system, but for continuity of care. What actually brought them to the hospital to begin with? And we can find some of those very early symptoms through those ER notes that would be missed if we just started with where the patient was admitted. And speaking of the patient being admitted, we've come across some situations, several lately, in that we go to bill and it's denied because the patient did not have a qualifying hospital stay because they had observation stays during the time they were in the hospital. So in trying to create a safety net for that situation, we did put a link on here, a situation where a spot where you'll say for the evaluator, we're asking you, was a MOON form issued? So many people didn't understand or know what the MOON form was. So we put an attachment right here in the electronic format of this tool. And it shows you the Medicare Outpatient Observation Notice, MOON. This is something that is delivered by the hospital to the patient while they're still in the hospital. And it basically tells them that they're in they've had observation days while they've been there, and that if they need to go to a nursing home after they leave the hospital, that we can only cover them if they had a 3-day minimum medically necessary inpatient hospital stay. And it tells them that the inpatient stay begins the day the hospital admits them. All right, so they need to make sure that we haven't been issued that the hospital did not give one of these to the patient. So we want to ask that question, did you receive one of these forms? Did you receive a MOON form? So that way we know when the patient is coming to us, did they truly have a 3-day qualifying hospital stay? Or were some of those days observation? And it can't be that you limit this question to people who've only had a 3-day stay in the hospital, because there are observation stays that have gone 2, 3, and 4 days long. So it's very important for you to identify that and really try to get that information ahead of time. So I know that there are a lot of people who weren't familiar with what that form was, but now we'll start to ask that question. It's much easier for us to start that inquiry when they're in the hospital setting than to do it after we've already billed and then try to go back and find that information later. So we're really hoping that this tool will take off and be something that's very effective for everyone who will be using it in the different fashions. Again, it's already been started to be used. People are going to tweak it, but what we do ask is that we don't all of a sudden have 28 variations of this. So everyone's going to use it, make their suggestions, and then we're going to come up with one final tool to use before October 1. All right, thank you so much, and have a good day.